teacher and orator, but also a prolific writer who has significantly contributed to the field of diabetes through his research and publication. Dr. Chandalia has played a pivotal role in elevating Indian diabetes journal, books, and magazines to international standards. His active research in the areas such as glycation, lactic acidosis, obesity, and diabetes education has led to the publication of over 80 articles and contribution to more than 50 books. We are privileged to have him share his insights and expertise with us today. Without further ado, we welcome you, Dr. Chandalia. Please go ahead with your presentation.
Thank you, Doc Plexus, for bringing us together, and Dr. Shithil for my introduction. Dear colleagues, I'm going to discuss today a topic of immense clinical importance to you. Those of you who want to use insulin efficiently have to develop your strategy to minimize hypoglycemia during insulin therapy. So I'm going to discuss these strategies, and the outline of my talk is here. We'll first talk about high incidence of hypoglycemia with insulin therapy. Dangers of hypoglycemia, very well known to you, so I'm going to go over very rapidly. And then we go to why exactly hypoglycemia arises in insulin therapy. Obviously, it is inappropriate insulin and insulin at the wrong time, not matched with meal and exercise. And of course, how to minimize those strategies will sharpen some special situations where hypoglycemia is more likely or more dangerous we discuss, and then we'll wind up with some key points. So hypoglycemia with insulin therapy is a common side effect, very well known. And some of these studies, you can see UKPDs, insulin, absalpon, ureas were the prime agents causing hypoglycemia. And insulin lot multiple about 3-4 times more than even glibenclamide. So you can see how important it is when you treat people with insulin. And remember that whenever you are intensifying treatment, even in clinical practice, when you want to improve treatment in a patient and we bring it to the best possible, like A1C, not 7 only, but 6.5, 7, you are going to 6.5, 6 even, you are going to face distressing incidence of hypoglycemia until you are very smart to understand how to do it. And again, it is the same thing about hypoglycemia frequency and threefold increase with intensive therapy. So those of you who undertake intensive therapy have to learn these techniques. And of course, when we ask a group of doctors, primary care physicians, what prevents you from initiating insulin therapy? And they say the main thing is, or for that matter, any glycemic management, the main thing is the fear of hypoglycemia. And that prevents many of you, good healthcare professionals, to undertake this sort of therapy, that is with insulin. Now, dangers of hypoglycemia are many. Most importantly, in all studies, you will see that hypoglycemia with intensive treatment is associated with weight gain. So this is another consequence of recurrent hypoglycemia, because there is defensive eating by the patient, and therefore the weight gain can be quite marked. So this is one reason why you have to avoid. Besides, of course, immediate dangers of hypoglycemia, which are very well known to, so I won't go into detail, but remember that many repeated episodes, we don't say that very frankly to our patients, but can lead to cognitive impairment. And I think this is very well worked out. But while talking to patient, unless there is good likelihood of hypoglycemia, we don't know to bring out such kind of statistics. And here 3 studies where a little bit intensive control was tried, and you see compared to standard control how much more hypoglycemia occurred. We learned from a core study, which was prematurely terminated for the reason that intensive treatment where the A1C goal was like 6 and a rapid lowering of blood glucose, you see, produced higher mortality, cardiovascular mortality. And that alerted us, and we learned from these 2 important facts, which are there in the last 2 lines here, that if a patient has pre-existing cardiovascular disease and you see who can really be suffer from bad hypoglycemia, there the intensive control, you see, he, he you know, is beneficial. But pre-existing, you see, where without the pre-existing cardiovascular disease, you can control a patient very intensively, so that prevents the cardiovascular disease. But somebody has a severe cardiovascular disease, before you control intensively, be careful, because it can be detrimental to the patient. So this is very important. In first 5 years of diagnosis of type 2 diabetes, you attempt intensive control, because as we learned also that by a glucose memory effect that is translated into benefits extending over 10, 15 years after stoppage of treatment, or after going back into the standard therapy or relaxing therapy. So later on, even if the control is not as good, you see, it is not going to have some immediate cardiovascular effect. How does hypoglycemia arise? This is the typical blood glucose profile. In green is a normal person, non-diabetic, and in the red and yellow is a diabetic. With the basal in red, that is also raised, and prandial peaks are also raised. So we have to address overall issue, but sometimes we divide it into two parts: approach to basal and approach to prandial. Ultimately, when there is global hyperglycemia, we have to control both of them. Now we have, of course, so basal and prandial hyperglycemia. You see, the basal is primarily due to hepatic glucose production. If you know that insulin therapy given in the evening, a good dose will really suppress the hepatic glucose production most efficiently. Metformin does that also to some extent, and of course, it's one of the main effects of metformin. And partially post-meal hyperglycemia. And very important to realize that the basal insulin almost makes 40 or 50%. Basal need on meal related without eating, a patient requires whatever is the total dose, 40% of that. We utilize that when we transfer patients on pumps, that whatever is the total dose, 40% we try to put in the basal and then fractionate further. Those strategy I won't be discussing today, but this is very important concept, because overall we have seen that in our country a lot of prandial insulin is used. Both basal is started but never titrated to adequate dose or adequate proportion in the total dose should be about 40 to 50%. That is not done. And of course, this insulin is required. It is used by the liver to a great extent, you see, and that reduces, you see, 40, 50% insulin therefore has to be go into the liver, where it has very, very important effects. When you start insulin therapy, we say first, fix the fasting first. So sometimes we start with basal and we do that. But remember, whether it is basal or prandial insulin, basal itself also can sometimes bring down the prandial glucose, because overall the whole profile shifts downwards, as you saw in these slides. And therefore, beginning with basal also can control some not too intensive prandial peaks, but moderate prandial peaks can be controlled by that. And of course, the basis of insulin therapy, I wanted to understand a few points from this slide. Taking about 100 units insulin required by anyone. This was done by earlier when we used to do a lot of research studies with glucose control infusion, insulin infusion systems for research purposes. And there we learned that half of the insulin requirement you see here is 32% of basal is at night, and the basal between the meals together, it comes to 40 to 50%. Half is prandial, and before breakfast dose is higher than any other dose quite often. Not necessarily so, but many patients it is high, and therefore breakfast dose of prandial insulin has to be high. See, it is unrelated to size of the breakfast, amount of carbs, but it is really what we call chronobiology of insulin action, or chronobiology of other hormones like growth hormone, cortisol, which all are peaking in the morning hours. And subsequently, I think although shown here, the dinner dose may be really the next, and lunch dose is usually a bit smaller than these two doses. So important to understand this, because not many doctors understand and undertake insulin therapy, what you call basal bolus therapy by by understanding these principles. If you do that, you get good control very fast without hypoglycemia. So this kind of doses come, so I will not go further. Now, this is very simple point which sometimes don't see carefully. We miss out if you don't see the insulin injection sites. And the patient injecting in the same place, which becomes a little bit numb and more comfortable to inject. You see, repeatedly doing that and saying morning I inject this side, evening that side, that doesn't mean that they're really rotating insulin injection sites. Rotation is shown here beautifully as we have been teaching, not any of those very interesting U-shaped charts are given by industry, but very simple, 3 lines, one in navel line, one above, one below, and whatever, 2 shots, 3 shots, 4 shots, they are given in one line, the second line next day, and then third day. So same point you'll reach only after 6 days. This is very important because from lipoatrophic sites, insulin absorption will be very erratic, and it can really confuse you, and then need to increase our dose and the hypo and end up into a very vicious cycle. Now, another very important point I wish to make, see, that you can go by basal plus 1 dose of meal-related or prandial insulin, that 2 and then 3. Remember that as we go along, you'll find that as you increase the number of doses, actually the control becomes easier and hypoglycemia becomes less, and A1C finally achieved is much better. So don't hesitate to start multiple doses. The current insulin injection, needles which are 4 millimeter, 33 gauge, something like that, and very hair thin. I think the pain component is virtually nil, except it is a little bit inconvenient. But that inconvenience people have to undertake. And therefore, don't hesitate to prescribe multiple doses. Here also you see 1 versus 2 versus 3 doses. See results here, OD dose, 2 doses, 3 doses, you see. So multiple doses should not deter you. If they are required, please do that. Because in fact, you're doing a great service to patient, and patient won't get because everything gets divided. So none of the doses are very used to cause hypoglycemia. Another important thing is we have to understand insulin's what is called pharmacokinetics of insulin. And you see the compared to analog like Lispro or Aspart or glulisine, you see compared to that, those to human insulin is not very sharp in its action. It starts much later, after about an hour, it peaks and then continues for not only 2 hours, but 3 or 4 hours. So interprandial hyperglycemia is more with human insulin. Postprandial also hypoglycemia, intercurrent hypoglycemia is more with human insulin. And of course, the postprandial peak is also high with human insulin. And that's why we have difficulty with this particular, although human insulin still should be the main sheet anchor of treatment. But if you have difficulty about these things, these two aspects, then I think you should think of introducing an analog. Now, insulin hypoglycemia less and less as you start very good insulins. You see, like newer insulins, So newer insulin, you see, and we take up case of, let us say, new basal insulin. I don't want to go into complete development of insulins, but look at NPH and then look at Ditimer, and then you go to something like Degludec, So when you have these, you will find that hypoglycemia becomes less and less with your insulins. Why? Because they do not have as much coefficient of variation. So say basal insulin, now we have developed NPH, we did 2 times. That is still poor person's, basal insulin twice a day. And that is mainly used in pregnancy and glargine, and then glargine 300 and Degludec. So development, you see the last two, you'll see that their blood glucose profile, that basal, which should be a uniform curve, no peak, you see, and you find that, with the better insulin like ultra long, which we say, let's say the glargine 300 or Degludec, you find that the excursion become much less. The fluctuations are much less. It's a very steady, it rises, it's a very steady supply of basal insulin. So automatically hypoglycemia becomes less. You see, and between the same subject, variability day to day becomes much less, much less. See, so very steady delivery into the bloodstream of these insulins. And of course, there is an old study, but very statistically showed that NPH, biphasic, or even biphasic aspart, which is like NPH, but an analog, see, hypoglycemia and weight gain, if you see, and they go parallel, as I told you, right, to start with. So you see, and prandial aspart you see also at basal. Now you see the rate of hypoglycemia is maximum with long-acting biphasic aspart. It's like NPH human. You see the biphasic aspart is analog, but hypoglycemia, prandial insulin, the hypoglycemia is very high, the quick-acting ones. And basal, as you get better and better, hypoglycemia becomes less. So overall, it also tells you that use basal insulin adequate because hypoglycemia can occur with any insulin, but the sharp, very, very disturbing hypoglycemia occurs with short-acting insulin called prandial insulins, which means human regular or any of these quick-acting asparts, like quick-acting analogs like aspart or lispro or glulisine. So again, the variability of, let us say, NPH, which was a mainstay of treatment 20 years ago, you see, day to day, these are a different profiles can occur with the one shot of NPH. So you can see how much variation is possible. So less variation will be very important. And the coefficient of variation is very important. You see, regular insulin, human regular even is only 20%. 20% you'll think is high. In fact, in insulin, this is much less. 20% is acceptable. But NPH up to 30 or 40%. And lispro-aspartic at 20 and glycine datimer also 20 to 40. But the newer analog, basal, which are further improvement, it is slowly coming down from 40 to 30 or I hope to 20. So the day-to-day variation in the same person, the same dose, the same diet, the same degree of activity, you can get different glucose profile. So another way to, of course, completely skirt around the incidence of hypoglycemia almost with great efficiency is use of insulin pumps. And the one reason there is that insulin pumps, the absorption variability of insulin pumps is 3%. So variation, the coefficient of variation is 3%, which was 20 or even 40 with other insulins. And therefore, pump, you see, it does not give you as much hypoglycemia. Now, when we have the algorithms for treatment, this is simplified earlier version in order to illustrate my point that when you use the triple, you see second row of the drugs you see, you use triple oral combination, 4 drugs you see, and then you introduce insulin, see. And then, sometimes you think that let me remove oral agents, but that's a mistake. Not that you continue all of them, but there are some which are required. For type 2 diabetic, sensitization to insulin is one of the most important study. If you don't sensitize them, you see the insulin dose required will be very large, and large doses are always fraught with danger of hypoglycemia. So sensitize them. And what kind of hypoglycemic or hyperglycemic drug you will use in order to sensitize. So when you sensitize to insulin, analog, DPP4 inhibitors, SGLT2 blockers. There are a big group of drugs which can do you that, which can, you see, sensitize the patient to insulin. While on the other side, sulfonylurea and ripaglanide or netaglanide and insulin, of course, will cause hypoglycemia. And therefore, when you sensitize, sulfonylurea combining with insulin, use very carefully. But remember, the most potent agent to sensitize is not pioglitazone, as you will learn from your routine literature. Most potent is sulfonylurea. So if you don't use long-acting, use fractional doses or short-acting sulfonylurea, and you'll get away without much hypoglycemia. These are very important keys to success in general with insulin therapy. When you have a lot of hypoglycemia, you should seriously consider reducing your A1C targets. And this is from one of our papers where we propose these targets in different type of diabetes and different phases of a diabetic life. Like type 2 diabetes, long standing, instead of 6.5, your A1C goal can be 7.5. Type 1 diabetic is 7.5 is very good with standard therapy. It's only with pump therapy you can go to 7 or 6 or 6.5. Don't attempt anything more than that because it causes a lot of hypoglycemia. And in pregnancy, for the first time, we propose that gestational diabetes targets A1C, pre-gestational type 2 diabetic, already pre-existing type 2, becoming pregnant, and type 1 diabetic very pregnant, the A1C goal should be different in pregnancy, which is not yet been very well brought out in the literature, but this has been proposed by us some time ago in a published paper. Because these three again are different. So A1C goals, you have to be careful with a lot of hypo. You should think whether you should revise the A1C goals. Then, of course, sometimes monitoring is very important, and ambulatory monitoring with a sensor will give you very great insights. Please make sure for patients to maintain multiple blood sugar charts also, and also food activity chart maintain and correlate with the sensor. Otherwise, the sensor is just a gimmick. Putting a sensor and observing those curves is a gimmickry unless you really know how to interpret it, and the patient takes extra trouble in maintaining charts, especially their food and activity charts. So minimizing hypoglycemia, individualized targets, you can use more monitoring like CGMS sometimes. You see patient education and sensitize patient type 2 diabetic insulin action, and if possible, use the newer analog. They're highly expensive. But some places where you are facing difficulty, you may have to take them, and let us hope we have insulins which are better and better in the variation effect they produce day to day in the same person. So very few special situations where hypoglycemia is very frequent and you need to be very cautious, I'll tell you, is nocturnal hypoglycemia. And it's very disturbing and very dangerous. See, so if you have that and your patient has multiple doses, let's say human insulin, then this is one indication where human insulin before dinner should be replaced by an analog, because human insulin will continue its action for 5 hours. And that coincides with the chronologically hypoglycemic hypoglycemic nadir that we human beings have, that is between 3 a.m. or the very typical time, 2 to 4 a.m. is the maximum incidence of hypoglycemia. Because it's a diurnal rhythm in our body to go a little low at that time. And then you give human insulin cause problem. So this is one situation where appetite, although I don't advocate you give it to everyone, but this is a situation we should consider. Nocturnal hypoglycemia is dangerous for one reason, that whatever counter-regulatory responses we have to hypoglycemia are really mobilized very well when you are up and about. The recumbent position, those reflexes don't come into action very fast. Catechols don't get bored very fast, and therefore, they go into hypoglycemia very precipitously. And remember also in the elderly people, there is a gap between the perception of hypoglycemia, which is very close to at 68 milligram percent. Beautifully you work now, 68 milligram percent is beginning of hypoglycemia. And there you have sympathoadrenal discharge, which you recognize as harbinger of hypoglycememia. And then the last one where the person passes out and the cognitive function goes away. So that gap is normally big in diabetics, but in the elderly people and in very long-standing diabetes, this gap gets very narrow. So these people you have to be very extra cautious, and cautious because they can suddenly go into unconsciousness and drop. So this is very important. You take very special care. Many of them may require multiple insulin doses. Sometimes they should be on insulin pump, and sometimes we may have to even relax the treatment a little bit. Some of these people sometimes are classified impaired awareness of hypoglycemia. So be careful when you treat them, and see you can actually try to increase that awareness by slightly relaxing the metabolic control, because hypoglycemia is immediately dangerous. And now we have studied to show that those who suffer from recurrent hypoglycemia are prone to cardiovascular disease in the near future, multiple attacks. And you see there are reports now proving that hypoglycemia is injurious to cardiovascular system as well. So I think it's very important to revise your targets in these people. Hypoglycemia unawareness also will occur in long-standing diabetes. Diabetics on very intensive control, they become quite unaware, including with pump, they can get unaware. Alcohol can blunt this. The recognition of hypoglycemia is very dangerous in people who are prone to hypoglycemia, because itself is a very, very important cause of hypoglycemia in countries where alcohol is more rampant. And hypoglycemia can cause sudden autonomic failure, where blood pressure drops. Under anesthesia, this can occur. Obviously, patient is unaware, and therefore anesthetists always tell you that please allow me to keep the glucose is little high, because they can't make out difference between hypoglycemia and you see anoxia, which can be produced during anesthesia. So all the time they tell you. See, and of course, regular doses of beta blockers don't really block completely. So although you keep worrying, but that is not the cause. So you see, unawareness, you relax the control for a while, and then maybe continue that way. So if you tighten the screws again, you get into the same problem. So you'll have to revise your goals permanently, little bit upwards. So key points very quickly: hypoglycemia is frequent in insulin, sulfonylurea, urea, and like ripaglinide and this kind of compounds, and you see you should use some other compounds, as I told you, in clinical practice as much as possible. Hypoglycemia is risky. I made it abundantly clear. And of course, you always improve your insulin plan. You see, review the injection technique of these people, see whether they're rotating sites, use multiple small doses. Don't try to say, I'll control you with 2 doses, I'll control you with 1 dose. In a difficult patient, you have to do that. You see, an adequate basal you use for the reasons I told you, and use good insulin with less coefficient of variation. So remember that even the human regular also coefficient of variation is less. That's why some of my teachers, for example, told, why don't we give just 3 doses of human regular? See, and I think it was quite rational, much less hypoglycemia. And of course, with the analogs, even it is less than that. And of course, sensitize the patient to insulin and set realistic A1C goal. See, nocturnal hypoglycemia dangerous, I told you, and you must know how to avoid. Maybe a bedtime snack in some of these people is important. Elderly subjects, you have to be very careful about hypoglycemia unawareness and nocturnal hypoglycemia. They may not have anyone living with them, and they pass out, and then there will be nobody to really help them. See, and to see the glycemic goal may have to be revised. So thank you very much. I must be ready to take any questions you may have connected with today's topic.
Yes, thank you for that wonderful presentation. And it was really wonderful listening to you. Got to learn a lot. So we have a few questions. Can we go to the first question?
Yeah. Can you hear me, Dr. Shidhar?
Yes.
Yeah,
Doctor.
okay. Go on. Yeah.
So my first question to you is,
sorry, am I in still?
Yes. How?
Yeah, okay.
I can see you, sir. Yes.
Yeah.
So how do you approach the creation of individualized insulin therapy plans for patients with varying degree of insulin sensitivity?
Yeah. First of all, I think all the type 2 already received earlier oral agents. So at least I will retain metformin and as a basic sensitizing drug. And if required, then add other sensitizing drug. And I think you go really stepwise, a good idea. because many patients manipulate both the basal glucose as well as prandial by good shot of basal insulin. So we do that. You have to individualize, which in advance is difficult. Type 1, of course, remember that never attempt these 2 doses in all type 1. 4 doses, basal bolus is absolutely required. Don't play with any other kind of insulin therapy in type 1. Don't do that. Unless very rarely you get a little stable type 1, those are very rare. The C-peptide is not very low and they don't fluctuate as much. Then you can do with simpler regime, but it's impossible. So type 1, see, just don't attempt, anything like less than basal bolus therapy. Type 2, you see, individualize. You see how bad the A1C is, and especially there is a weight loss. There is weight loss. Remember that you must introduce insulin therapy in type 2 with the rapid, undesired, means patient was not unplanned weight loss by the patient, without any efforts. And that shows that insulin has to be introduced. And there you can go the stepwise. Only those who are very high, like 9 A1C or more, you see, I would straight initiate them also with basal bolus. Sometimes you are able to create basal and one big shot of bolus, and there are insulins. We combine the both also. A single shot at the main meal. But there is a very small number which are salvaged by these maneuvers. Those who really need insulin badly, ultimately need it in a most physiological way, which at the present time, what comes close to physiology, normal physiology is 3 shots of prandial with every meal and 1 basal for 24 hours, a good basal. So I think we have to go to that. And more people with long-standing diabetes, also remember it won't be very easy. 10, 15, 20 years of type 2 diabetes, and we are playing with oral agents, you will not succeed. And even the single shot of basal, you will not succeed. So long-standing diabetes, very high A1C, a rapid weight loss indicates profound endogenous insulinopenia. And I think the replacement has to be adequate, not half-hearted, and that means basal bolus therapy. And this can be accepted by patients if you really convince them that this is the way to help you. And otherwise, of course, they go through bad experiences with 1 dose, no dose, 1 dose, and 2 dose, and all that. Those mixtures, pre-mixed insulins, which had a sway for a long time. Now in the literature, many proponents of insulin therapy, the big authors, big names who really are the opinion makers, they started writing that these mixtures are no good. Earlier, for 20 to 20 years, they used mixtures, and they published a lot of papers themselves on mixtures. So I think this is changing scenario, and please don't hesitate to undertake insulin therapy the way I showed you, with multiple doses and sensitizing patients properly, and synchronizing. You see, meal, insulin, exercise very well. Learn the effect of exercise as well, really. So I think type 2, you can go stepwise, except those who are losing weight, A1C more than 9, 10, 15, 20 years of diabetes. I think, again, straight go for basal bolus. I really don't go through those steps in those difficult patients. Those my other colleagues have already done before patient comes to me. So my task becomes easier because I know why they didn't succeed. So I go straight towards the success. And they're the mantras of success I have given you today.
Thank you for that wonderful answer. Moving on to the next question. So my next question to you is, what monitoring protocols do you recommend to promptly identify and address hypoglycemia in patients undergoing insulin therapy?
Yeah. Now, those who are on insulin therapy, they require checking little more intensively than others. Remember that all diabetics don't need that every day 2 samples, 3 samples of 5 samples, certainly not. And during the titration phase is different from the stabilized phase. The number of blood sugars should do. So monitoring with insulin already the patient is taking has to be a little more frequent. Initially, when you are titrating, I would at least monitor, minimum is 4 times a day, maximum 6 times a day, before each meal, 2 hours after each. Otherwise, I do keep before meal every day, all three, prandial one by rotation. One day after breakfast, next day after lunch, next day after dinner. So this is the way, and you can still titrate insulin. And after titration phase is over, and patient is very well stabilized without much hypo, without much hyper, A1C has reached almost 7. At that point of time, I relax the control to, 2 a day by rotation. Never, if you have to instruct patient not to check same blood sugars every day. See, and patients soon identify which samples are good to show to the family that you can give me some sweets also because sugars are okay. Show that. So you have to see, so out of those 6 samples, 2 by rotation and complete a rotation in 3 days. Very smart way, only 2. And when they get fully stabilized, sometimes I'll go once a day again by rotation. This is very important. Don't keep checking. The patient's checking fasting every day. There's some who are very fond of doing it while going to the bed. See, but they need to rotate the blood sugar estimation. So monitoring also have to be very smart what you advise. And very rarely those sensors are required. Unless used properly, sensors in our country are being used extensively now. I congratulate the marketing skills of the industry for that. See, but I don't congratulate the patients for that because they put it and go on looking at those curves and they have no idea what to do. And then they think very smart. They don't consult a doctor who understands, and they just do lab tests and they think they know everything about diabetes. Very, very unfortunate, those patient attitudes. It take you quite some time to convince that it's worth making some regular visits to a doctor who understands this. So unless with those sensors you do, I tell them to even record 9-point chart. Besides all those curves, curves are giving you trend. I want to know that. And remember, blood sugars is not accurate at all in the library, freestyle library. See, the sensor can be way off. If you check with your meter, you'll be disturbed. Sometimes you tell patients not to check also. But I tell them you're suspicious because in terms of hypo, the library says whatever it says 90, check with your meter, you'll find it 50 or 55. So they have to understand that. But they are very good for studying the trend and finding out where is the problem, little bit locating it. So I use it very, very sparingly. You can use it intelligently, for God's sake. Don't keep on putting this, you see, because it increases the cost of care hugely. But there are people who can afford and they like to use it like an ornament every day. See, ornamental value they have, sensors. I'm putting it on every day, doctor. See, so please try to understand this. You judiciously do use it. They're excellent the way if you know how to use them the right place. Very fine tuning. Somebody at 300, 400 blood sugar, what is there to put sensor in? See, when he comes down, then you want to fine tune it, then you put a sensor. Fine tuning. See, where is the problem? Where are little lows? Exercise is evening 6 o'clock. Effect comes after 1 hour, 2 hour, 3 hour, 4 hour. In a given individual, the physiology varies, exercise effect. So once you study and once you learned after how many hours exercise effect comes, a given individual, you can tailor your dose beautifully. See, so you need accurate insight. You have to know what you're looking for. Otherwise, whatever you see, you cannot learn anything unless you know what to look into that. So please learn that. Please learn that.
Thank you for answering that. Moving on to the next question. So my next question to you is, since you spoke about technology, so how has the integration of technology, such as continuous glucose monitor, impacted the management of hypoglycemia in insulin-treated patients?
Yeah, you should actually use the technology judiciously. Type 1, I would love to use as much as possible. Type 1, because it's a constant problem, hypoglycemia. Type 1, most of the time we have good number on pumps. Some of them are 30 years I have on pumps. See patients, and they have to now, they all gone to automated pumps or semi-automated, I call it. You see, where there is a sensor is integral part of the pump. So that is beautifully censored. Those estimations are more accurate, by the way, I must tell you very frankly, because those pumps, depend upon accurate estimation. Those sensors. If they can't accurately estimate, how will they cut off at 70? You have put it in the pump and it doesn't cut off, and sensor is haywire, and you're off by 20 milligram. Patient will be unconscious before you realize what happened. So they are accurate. They are accurate. The Guardian 3 sensors there, and we are even looking at now whether we can use those, without the pump. There are investigators who told me from other countries who treat a lot of type 1 in some sessions where we were discussing things, of this type, pumps and their use. And they said that now sometimes they use those good sensors, regularly, and without putting the pump, the patient takes doses, understands doses and takes with high and low. Anytime the little high knows how to shoot in 2 units, 3 units, and they sometimes achieve as good A1C as people on pumps. It is possible. Somebody doesn't want to go for the pump. So this sort of things is possible. So please integrate them, individualize use of sensors. They are beautiful tools, They're getting more and more refined, they're getting better and better. And some of the drawbacks, I'm sure science will remove those scientists who are making them. One day they'll remove and we reach a little more perfection. But some sensors are already close to that perfection. And some of them still help you. Your EG availability, you see the trends for 2 weeks with Libre. So it gives you a lot of insight. But continuous use is more of type 2 is really bad. Type 1, you can use. But then when accuracy suffers, then type 1 you can't handle because you need reasonably accurate for hypoglycemia in type 1, And so I think there's some limitations, but they are good. Please integrate them with your treatment. How frequently to use, which patient to use, which patient has to go on pump, which patient has to regularly go on sensor, which patient you really require only by titrating doses, titration phase, fine-tuning phase. This is so please integrate them. Yes, integrate. But as industry say, integrate with everyone. That's a business. That's a business sense. That is not technical. Scientifically not correct.
Thank you for that wonderful answer. And with that answer, this brings us to the end of this session. Thank you so much, Dr. Chandalia, for that enlightening and comprehensive discussion. Your insights and expertise have provided us with deeper understanding of the complexities and considerations of minimizing hypoglycemia. We appreciate the time and effort you have taken to share your knowledge and experience with us today. It has been an invaluable session for everyone involved. Thank you all to our attendees as well for your participation, and we hope you found this webinar beneficial and that it will enhance your practice and patient outcomes. Please stay tuned for future webinars and have a great day ahead. Thank you.
Thank you. Thank you.